Hello everyone, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. We shall today discuss early management of severe trauma. In the end, please subscribe to our channel and give us a like if you find the lesson useful. So let us not waste time anymore and start right now. The initial trauma assessment according to the formula patient plus mechanism equal to injury provides the necessary information to formulate and carry out the initial treatment strategy. During the initial stage of care, the injury continues to evolve and deterioration may occur suddenly. A strict watch is required throughout the management to identify the potential depletion of reserve homeostatic mechanisms. To study further, you may watch the video Metabolic Response to Trauma and Surgery Parts 1 and 2. The links have been given in the description box. After the injury, a series of homeostatic and metabolic responses are initiated and exaggerated in an effort to ensure survival. These responses change with the passage of time following injury. The management and intervention should be altered accordingly. Important observations that need prompt attention include tissue oxygenation, body temperature, and organ perfusion. A low body temperature is a frequent finding after trauma. It may be due to environmental exposure, blood loss, and inactivity. Measures should be taken to prevent further fall in the body temperature and restore it. During transportation, resuscitation, and in the operation theatre, the patient should be covered with appropriate clothing such as blankets. This will minimize the risk of hypothermia, coagulation abnormalities, and further bleeding. The tissue oxygenation can be improved with the administration of supplemental oxygen or mechanical ventilation as needed. A state of shock with an altered level of consciousness, low blood pressure, tachycardia, and diminished perfusion of the extremities marked by pale or ashen skin may be caused by the ongoing blood loss. A small amount of bleeding, that is, loss of less than 10% of the blood volume, is tolerated well by most patients. A larger amount causes shock, leading to cellular dysfunction, organ failure, and eventually death. Hemorrhagic shock and brain injury cause most short-term deaths that occur within hours. The traumatized body activates endogenous clotting factors to stop the bleeding and to maintain adequate blood volume. Since the lungs cannot tolerate much extra fluids, according to the latest resuscitation guidelines, it is transfuse blood products early in a state of crystalloids. Also, there is a need to quickly identify and stop the source of bleeding. Traumatic injury upsets immune system homeostasis and activates pro-inflammatory and counter-inflammatory responses mediated through macrophages, T cells, and B cells. After any kind of trauma, there is a complex interplay between the neuroendocrine stress response and the pro-inflammatory cytokine response of the innate immune system. Pro-inflammatory acute phase mediators such as interleukin-1, tumor necrosis factor alpha, interleukin-6, and interleukin-8 are produced within the first 24 hours of the injury. Therefore, surgical procedures can act as a second blow after the first injury and hence should be carefully timed and when a traumatized patient is found at the scene of an accident, the pre-hospital system should notify the receiving hospital before the patient is transported from the scene. The trauma team on call should be alerted and the treating personnel should be waiting for the patient's arrival in the resuscitation room. The team leader will instruct trained nurses and physicians to carry out specific tasks according to the Advanced Trauma Life Support Protocol or as per local or national guidelines. Common management algorithms should be followed to manage patients to save time and reduce errors. In locally developed protocols, someone should have the authority to change the protocol if this is required in the best interest of the patient. Early labeling should be avoided because it can be misleading. For example, an elderly patient with medical comorbidities who misses a step and sustains an ankle fracture may be just labeled ankle fracture. Now the pathway is set and she may be placed in a plaster of Paris back slab and admitted for open reduction and internal fixation under the care of an orthopedic personnel. Here the team may forget her multiple problems. The so-called benign bathroom falls may cause more severe injuries such as a trochanteric fracture or a hip dislocation or a severe head injury. Also, a patient may fall due to a medical condition such as a transient ischemic attack and sustain other injuries including fractures of the pubic ramus and ribs. The wrong labeling may hide the seriousness of the injuries sustained and the patient's condition may rapidly deteriorate. Early labeling after an inappropriate assessment can be incorrect and put the patient in the care pathway. All patients, particularly serious patients, should undergo physiological triage to reduce the risk of being wrongly labeled. After the initial assessment and resuscitation, next in-line interventions are taken in a polytrauma patient. In complicated injuries such as pelvic fractures, spine fractures, lower extremity fractures, liver injuries, and foot dislocations, the timing of fixation, the type of fixation, and the priority of treating different injuries have been controversial for some years in the past. Before the 1950s, polytraumatized patients with major musculoskeletal injuries were considered too sick to undergo major orthopedic interventions to stabilize the fractures. Pioneering work in the 1980s by Bone et al. Challenged this concept and demonstrated that early surgical fixation of long bone fractures actually was beneficial. His original work firmly established that early fixation of all long bone fractures within 24 hours reduced the pulmonary complications, length of intensive care unit stay, as well as the overall hospital stay in polytraumatized patients. Early definitive fixation of fractures allowed early mobilization and rehabilitation of patients and prevented the complications inherent to prolonged immobilization. This philosophy was termed early total care or ETC, which referred to the early definitive surgery within 24 to 48 hours for all long bone fractures in a polytrauma patient. This practice became the gold standard of treatment for patients with multiple fractures. But this early total care concept led to early complications and increased mortality in certain specific patient groups with severe chest and head injuries or those in an extreme hemodynamic state due to ongoing bleeding from different sources such as the abdomen, pelvis, and chest. The knowledge of the immune-mediated inflammatory response to injury led to the concept of the two-hit theory. The first hit represents the initial trauma that induces the inflammatory response. The second hit refers to the further physiological stress caused by the subsequent major surgical intervention. This led to a paradigm shift in the management of multiple injuries from early total care or ECT to damage control surgery or DCS and damage control orthopedics or DCO. The DCO approach consists of 5 stages. These are resuscitation, hemorrhage control, decompression, decontamination, and fracture splintage. The DCO concept applies to Physiologically unstable patients who are first stabilized using temporary external splintage or fixation followed by conversion to definitive fracture fixation with IM nailing or plating usually 4 days later. But on the other hand, a similarly injured but physiologically stable patient is managed with the early total care approach with IM nailing or plating within first 24 to 36 hours. These two approaches are being currently practiced based on the physiological and hemodynamic status of the patient. However, the vast majority, that is 80 to 90% of polytrauma patients, are suitable for early total care approach. ETC and DCO should complement rather than compete with each other. It is important to keep in the mind that the condition of the patient can change rapidly. High-risk patients can deteriorate quickly. Therefore, ongoing monitoring of the parameters such as temperature, serum lactate, blood gases, coagulation status, etc. will give knowledge of the patient's condition at any point of time during care. And appropriate decisions can then be taken to ensure the safety of the patient. For example, if the ETC strategy has been adopted and a polytrauma patient with a head and chest injury is waiting on the operating table to have a femoral fracture fixed with IM nailing and his condition deteriorates, then the ETC plan can be changed to DCO and an external fixator can be applied quickly to stabilize the femoral fracture temporarily. After that, the patient can be transferred to the intensive care unit where resuscitation can continue with ongoing monitoring of vital organ function. When injuries involve multiple organ systems, the most important intervention should go first. In mass casualty events, patients having greatest chance of survival and requiring the least expenditure of time, equipment, supplies and personnel are treated first. The mechanism of injury, that is, the type and the nature of the mechanical force applied, dictates the severity of the injury. The formula patient plus mechanism equal to injury should be kept in mind. All three components of this formula should fit together in an understandable way. When no relations can be made, look for pre-existing pathology and hidden injuries or suspect the history given by the patient, including deliberate attempts to mislead. Remember the timeline concept because there may be a minimum response time to initiate and complete the treatment. Assess and manage patients with multiple injuries as per the ATLS protocol or other local or national guidelines. Eliminate unnecessary delays by thorough preoperative planning. Ensure that no important parameter is left out. Follow one of the two existing fracture fixation strategies, ETC or DCO, in a complementary manner. Observe trends and identify promptly evolving conditions. Different patient groups such as the elderly and children have different demands and should be managed accordingly. Bone reduction treatment is essential for older patients who may be vulnerable to injury owing to poor bone stock and other comorbidities.